Pathophysiology of cardiac diseases in patients with liver cirrhosis. Cardiac dysfunction in cirrhosis is a well-recognized entity, often referred to as cirrhotic cardiomyopathy (CCM). It represents a complex interaction between portal hypertension, systemic inflammation, neurohormonal activation, and structural myocardial changes. 1. Hyperdynamic circulation early phase. One of the hallmark features of cirrhosis is hyperdynamic circulation, characterized by cardiac output, systemic vascular resistance, normal or low arterial blood pressure. Mechanism: portal hypertension gives splanchnic vasodilation, increased nitric oxide (NO), carbon monoxide (CO), endocannabinoids, reduced effective arterial blood volume, activation of ROS, sympathetic nervous system, vasopressin. This compensatory state maintains perfusion initially but chronically leads to myocardial stress and maladaptation. To cirrhotic cardiomyopathy (CCM), a systolic dysfunction stress-induced. At rest, EF may appear normal. However, impaired contractile response to stress exercise, infection, TIPS, surgery, blunted adrenergic receptor signaling, altered membrane fluidity, increased inflammatory cytokines TNF. USA's reduced inotropic reserve. B. Diastolic dysfunction, very common in advanced cirrhosis. Mechanisms: myocardial hypertrophy, interstice subendothelial edema, HSVC, collagen deposition, echocardiographic findings, impaired relaxation A reversal, increased LV filling pressures. C. Electrophysiological abnormalities, QT interval prolongation, altered potassium and calcium channel function, increased risk of ventricular arrhythmias. Mechanisms: autonomic dysfunction, circulating cardiodepressant substances, electrolyte disturbances. 3. Portal hypertension and cardiac load. Severe portal hypertension increases venous return, cardiac preload, wall stress. Procedures like TIPS may unmask latent heart failure due to sudden preload increase. For interaction with ischemic heart disease (IHD), patients with cirrhosis may have subclinical coronary artery disease, impaired coronary microcirculation, reduced coronary flow reserve, inflammation plus endothelial dysfunction plus metabolic syndrome, especially in NASH cirrhosis increase could risk. However, classical symptoms may be blunted. Troponin interpretation may be challenging. Hemodynamic instability more severe during ACTs. 5. Hepatorenal cardiac interaction. Reduced cardiac reserve contributes to hepatorenal syndrome, poor transplant outcomes, increased mortality during infections or GI bleeding. 6. Structural and molecular changes. Increased myocardial fibrosis, altered titin phosphorylation, mitochondrial dysfunction, impaired calcium handling, increased oxidative stress, clinical implications. Normal F does not exclude dysfunction. Stress echocardiography may reveal latent systolic failure. KT monitoring is important. Careful assessment before TIPS, liver transplantation, major surgery.